Hello, I'm Jo Richards and I'm here at the Perth Eye Hospital today where I've been operating. My private practice is at Western Eye and I also work at Royal Perth Hospital. I'm a general ophthalmologist, but I do have some special interests including inflammatory eye disease, which can often lead to glaucoma. And I see a lot of glaucoma patients both in my rooms and at Royal Perth Hospital, so I guess glaucoma is a bit of an interest of mine as well. Gaela has very kindly got together a big list of questions for me, and so I have a feeling about what people want to know about glaucoma. I realized that it's all to do with the electrics, plumbing and maintenance of the eye, so that's what I'm going to talk about today. So I'm going to start with what is glaucoma. It's not one thing. The glaucomas are a large group of conditions which all cause damage to the optic nerve head and potentially visual field loss, which can be central or peripheral. But the very good news is that we can often detect glaucoma before the visual fields are severely damaged now with the amazing equipment that we have. So visual field loss is not necessarily inevitable. In 75% of people with glaucoma, the pressure in the eye is raised, but 25% of people, it's quite within the normal range for the general population. And there are other really important features of glaucoma which determine how bad it will be, such as the blood supply to the optic nerve head and the optic nerve head's general resilience, which is quite genetically determined. So visual field is really what's most important, because that is what is going to affect people in their lifetime. So what does visual field loss mean? Anyone who goes to a glaucoma clinic will be used to having visual field tests, and it can be quite scary to look at them and see all these black patches and you wonder, is there blackness in my vision? But actually those visual field tests are a grey scale, and the blackness just means that your sensitivity is lower than would be expected for your age. It doesn't actually mean that you've got blackness or complete loss of vision. But the difficult thing about visual field loss is that the brain fills it all in, so people are not always aware of it until there is quite a bit of damage there. So in a full field of vision, this picture shows a little kid, actually my little kid when he was little, running along a road. If you have glaucoma and the child happens to be in your scotoma or your area of visual field loss, you might not even notice that anything's wrong there, because your brain is good enough to recolor the whole scene. It might not be in quite the same resolution, but you often cannot notice that there's anything wrong there. And that's why glaucoma is the silent thief of sight, because you just don't know until you test it. A symptom that some people do sometimes notice is that it takes them longer to find things. For example, when they're looking for something in the fridge, it's just not man blindness. You can't find the marmalade, and it can be because the marmalade's in your scotoma. If you look long enough, your brain will build up a reasonable resolution picture and you'll be able to find the marmalade, or otherwise you look around and the marmalade's no longer in your scotoma. So sometimes that's a symptom, is just things take longer to find. So what is the importance of pressure? I mentioned that 75% of people with glaucoma have high pressure when they're diagnosed, but then there's that other 25% who have normal pressure. Well, the really important thing about pressure is that to date, lowering the pressure is the most effective way we have found of stopping glaucoma from progressing, even in people who start with what seems to be a normal pressure. Lowering pressure has been proven to reduce the risk of visual field loss in all types of glaucoma, so it is our #1 priority. Some of you may have been told what kind of glaucoma you have. So it really is worth knowing that, because it determines how your glaucoma will be treated and what medications outside glaucoma are safe for you. So glaucoma as a broad group of diseases can be classified as primary, which is the genetically determined types, or secondary, where they're due to another disease. And in this picture you can see someone with badly controlled diabetes has had abnormal blood vessels grow on their iris and bleed, and that's what's caused the glaucoma. Another group which some of you may have been told that you have is ocular hypertension. Ocular hypertension is when the pressure is high in the eye, but luckily the eye is quite resilient and there is no detectable damage to the optic nerve, the visual fields, nothing can be found on OCT. But many people with ocular hypertension will go on to develop glaucoma, just like people with hypertension, in other words high blood pressure, can go on to develop cardiovascular disease. It's a risk factor for glaucoma. So back to the primary kinds of glaucoma, there's a big group of open angle glaucoma and narrow angle or angle closure glaucoma. And the open angle glaucomas can be classified into those with a high pressure and those with a normal pressure. These pictures down at the bottom of the slide give you an idea of what it means to have a narrow angle or an open angle. On the left, in the blue eye, you can see a big dome of the clear window of the eye, or the cornea, far away from a very flat blue iris, and so that is the typical appearance of somebody with open angle glaucoma. They've got a very deep front of the eye. On the left hand side, you can see someone that's got a very shallow anterior chamber or narrow angle, and you can see how the iris is bowed forwards like a volcano almost, and you can see all the details of the iris because it's almost touching the cornea. Most of us fall somewhere in the middle. I've added in one extra little picture just to the right of left, just to the right of the blue eye, which is a picture of a plateau iris, which is surprisingly common. So a plateau iris is shaped a bit like Uluru. It's got very, very steep, sharp sides and a flat top. And those people can look as though they have a very normal angle, but if we actually look into the angle with a gonioscopy, it is really, really narrow, just a tiny little sliver of access for fluid to drain out of the eye. And I'm going to show you in some coming slides what that means with a cross-section of the eye. So to start with, the very most common kind of glaucoma, which is primary open-angle glaucoma. 3% of people will have glaucoma by the time they're 60. Family history is really important. There's several dominant genes that have been discovered, but mostly it's a polygenic condition. In other words, it takes a few genes, maybe from your mum and your dad, to give you glaucoma. If you have a first-degree relative, it increases your risk 8-fold. So at age 60, that would be to about 24%. So anyone that has primary open-angle glaucoma should be advising all their first-degree relatives to be checked. That's their mum and dad, their siblings and their children. And the current guideline is that people should be checked 10 years before the age at which the index glaucoma patient was diagnosed. So if you were diagnosed at 50, your relatives should be checked when they're 40. Other risk factors include myopia or short-sightedness, migraine, cold feet, dementia, and there are some other slightly less important risk factors. Angle closure, which is the less common kind of primary glaucoma, gets much more common with age. A family history is also important because people inherit the shape of their eye from their parents. It's much more common in East Asia, places like Indonesia, very, very common. And hypermetropia or long-sightedness is a risk factor. Now, if you look in this picture, in the middle of the pupil, you can see a slightly cloudy appearance of a cataract. And angle closure glaucoma gets much more common with age because the cataract is the natural lens of the eye. It's actually embryologically a skin structure and it grows throughout your life. So just like your skin gets thicker as you age, your lens gets thicker and it grows forwards and pushes your iris forwards so that there is less space for fluid to drain out of your eye. So now we're going on to the technical side, but I hope that I will make it very understandable for you. So to start off with the electrics, the inner layer of the eye is the retina, and it's a really complex microprocessor it's got all the same layers as you find in the brain, so it is part of the brain. In fact, we like to tease the neurologists and neurosurgeons and say that the brain's just this tumour hanging on the back of the all-important eye, which is the important part of the brain. So the layers in the retina receive the light and process them into useful, meaningful information, and send the information to the ganglion cells, which are the inner layer of the retina that line the eye. The ganglion cells send a little stimulus all the way to the brain along the optic nerve. We can image the ganglion cells using OCT, or optical coherence tomography, and many of you will have seen your pictures like these in the clinic. It's pretty amazing that that little layer is only 50 microns, and we can look at it and see where it's wearing a bit thin. So in the bottom of that picture, you'll see a cross-section through the retina. That green line is 200 microns thick, which is 1/5 of a millimetre, so it's just amazing the resolution that we are able to look at things with nowadays. The really important part of the eye in glaucoma is the optic nerve head, because that's where the action happens in glaucoma. The optic nerve head is a thin little perforated area of tissue which is really like a trampoline. If your pressure is going up and down, the optic nerve bounces up and down, which you can imagine it puts a bit of stress on the tiny little blood vessels and nerves that are trying to get through and go to the brain. So that's usually where the damage happens. We can image the optic nerve head also with OCT. We look at the nerve fibre layer all around the optic nerve, and that's probably the most common way that we pick up glaucoma even before it shows up in your visual field. And then finally, visual fields. People hate doing them. They get stressed about it. Some people have sleepless nights the night before because it really is a very difficult test. You've got to think about whether you actually can or can't see the light because it's tested at such a dim level, and then you've got to press the button at exactly the right time and not be trigger happy. So it's definitely not a perfect test, but it's really, really important, because that is why we're treating glaucoma, to preserve the visual field. Now onto the plumbing, which mainly happens at the front of the eye. The aqueous fluid which fills the front of the eye is formed by the ciliary body, which is just behind the iris, and it filters blood and turns it into aqueous, clear fluid which drains between the lens of the eye, behind the iris, through the pupil, and then out through the drainage angle. The drainage angle of the eye is all around the edge of the iris, where the iris meets the cornea or clear window of the eye. And it's actually a pumping sieve. So it's not just a sieve, it is actually actively doing something, unless you've got the genetics for it to stop working. The fluid then drains out through Schlem's canal and drains away into the blood system and possibly into the lymphatics as well. So this is how we assess the plumbing of the eye. Up at the top is a gonio lens, which is a contact lens with a mirror in. Some of them have 4 mirrors. And when you put them on the eye, you can see round corners. So you can see into that little corner between the cornea and the iris and see whether it's narrow or wide, open or closed, if it's clogged with pigment or what's going on there. So that's usually how you make the diagnosis of what kind of glaucoma you're dealing with. The next little instrument down is an ultrasonic pachymeter, which tests the thickness of the cornea. If you have a very, very thick cornea, your pressure readings will often be much higher than they actually are in reality, so we take that into consideration. If you've got a very, very thin cornea, the clear window of your eye, it indicates that the other tissues of your eye may also be quite thin. Having a very thin cornea is a risk factor for glaucoma. Means that your trampolining optic nerve has a lot more give, so it's much easier to damage the little nerves that go through there. The next instrument down is a tonometer. It's a screening tonometer, and there are a lot of different kinds that are used for screening. Optometrists often use a puff of air. We often use a little one that bounces off the cornea called an eye care. This one's called a toner pen, and they're useful for just checking that your pressures are not super high, but they are not as accurate as the bottom one, which is the gold standard in measuring intraocular pressure. It's a Goldman applanation tonometer, and that's why your eye specialists put yellow drops into the eye. It's a contact lens. When it makes contact with the cornea, we can move a little dial to determine what the pressure is. Now I'm going to move on to glaucoma treatment, as I've had lots and lots of questions about that. I'm going to go through eye drops because that's really the commonest treatment that everyone is on, and then move on to the many types of laser and surgery you can have for glaucoma. So I think it is quite useful to think of drops and which part of the eye they work on. It's quite reassuring to know if you're on 4 drops, they're all doing different things, so there's quite a good reason to be on 4 of them. So I'm going to start at the front of this eye up at the top with prostaglandins. So the examples of those would be Xalatan, Lumigan, Travatan and Saflutan. They increase outflow from the eye through the uveoscleral pathway, which is the brown parts of the inside of the eye. Pilocarpine, a cholinergic, also increases outflow. Prostaglandins are pretty amazing. They're a designer molecule based on a biological molecule. If you can believe it, it is prostaglandin F2 alpha, which is the molecule that puts you into labor. So you can imagine there are some quite good reasons why we give these medications as drops, not by mouth. Because the side effects, you can get side effects from drops, but you can imagine what the side effects might be like if you took them by mouth. Moving back a little bit, the largest group of eye drops affect the ciliary body. They reduce the amount of fluid that's produced in the eye. Beta blockers are probably the commonest and oldest that have been in really frequent use. Timolol is the one that we use the most in Perth. And they, if you take them by mouth, they can be used to treat rapid heartbeat, high blood pressure, and anxiety. So even if you take them by eye drop, they can have those side effects if you're very sensitive. Most people don't get those side effects, but it is possible. Alpha-2 agonists also decrease aqueous production, and if you take them elsewhere in your body, well, they can be used on the face to dampen down the redness that you can get from rosacea. But if you take them by mouth, they can make you a bit sleepy, and some people even find that with eye drops. And then lastly, carbonic anhydrase inhibitors such as Trusopt, Azopt and Diamox are also used to decrease pressure inside the head for people that have raised intracranial pressure, and they're used to treat altitude sickness. So they're, again, something that you just need in very small doses in your eye. The good news in the last decade or 2 is that you can get these drops as a combination, so you can have something that both decreases your aqueous production and increases your outflow, such as Duotrav, Ganfort or Zalacom. Or you can have combination drops that reduce aqueous production, such as Combigan, Azaga, Cosopt and Simbrinza. One other little useful feature of alpha-2 agonists is they actually appear to protect the optic nerve, and they seem to have some protective effects on the macula and are on trial for dry macular degeneration. They will be used as implants if they end up working. So the pros of drops is that they're fairly safe compared with if you had to take them by mouth, and they're fairly predictable. They work for most people, but there are lots of cons. The main one is that if you have a dry eye, they make it worse, especially if you've got rosacea. And even if you didn't have a dry eye, you can get dry eye from your drops. Some people are very sensitive to them and can get side effects around the body. And the main drawback is they only work when you remember to use them. So if you forget, then your pressure goes up. On the same slide, I've got some information about other medications that can affect your glaucoma, and steroids are the most important. People have to take steroids for many reasons. For example, injections into painful joints, inhaled steroids for bad asthma, nasal steroids for hay fever, oral steroids for inflammatory diseases and autoimmune diseases. And there's unfortunately a gene, if people with that genetic type are exposed to steroids, their trabecular meshwork produces a gelatinous substance and gets clogged up and stops working. So the pressure can go up often around about 6 weeks after starting steroid, but it can be really quick. Some people it can happen in 2 weeks. In fact, about a third of the population will get a pressure rise from steroids, and if you put a high enough dose in, for example a steroid implant, then almost everyone will get a pressure rise if you put in enough implants for long enough. So people with open angle glaucoma need to worry about steroids. People with narrow angles need to read the package inserts, and this is a common cause for us to receive phone calls at our practice. People are worried, they've read the package insert, they've got glaucoma, is it okay for them to take this medication? Well, decongestants, antidepressants, antihistamines and that class of drug make narrow angles narrower by dilating the pupil a little bit. So if you're someone who definitely has open angle glaucoma, you don't have to worry too much if it says caution in angle closure. It's the people with narrow angles that have got to worry about those medications. Now onto laser. I thought that my big diagram might not explain it quite as well as a photograph. So the oldest kind of laser that we've used for glaucoma is a peripheral iridotomy. If you look at the top of that beautiful hazel green eye, you can see a little black round hole which has been punched with a laser. So that is a person whose lens has grown big enough to block up the pupil so the fluid can't flow through to the front of the eye, and the iris then comes forward and completely blocks up the drain of the eye. So if you make a tiny little hole at the peripheral part of the iris, it's just an alternative pathway for fluid to come through. Something that can be done instead of doing an iridotomy is a cataract operation. That also makes the lens much smaller, because artificial lenses are a third of the thickness of normal human lenses, but a cataract operation is a much, much bigger operation than a peripheral iridotomy. Peripheral iridotomy is just done on the slit lamp in the clinic. It takes about 5 minutes. You don't need an anesthetic or anything. More common even than peripheral iridotomy now is selective laser trabeculoplasty. It was preceded by a procedure called argon laser trabeculoplasty, but in the last decade or so, SLT has become increasingly popular, particularly after a huge trial that was done in the UK over the last few years, more than 10,000 people. It was found that people who had SLT did better than people on drops. In other words, their visual field survived better. The probable reason for that is you don't have to remember your laser. Once it's done, it's done. It's not like having drops that you have to remember them every day. The problem with SLT is it works for 60 to 80% of people you do it on, but the rest it doesn't work very well, and it's quite unpredictable. Some people it works immediately within 1 day, some people it takes 8 weeks to work, and then it frequently wears off after about a year. I do have patients that I did it 6 years ago and they're still going strong and haven't needed any more laser, so you can get really lucky with it, but the majority of people end up having to have it more than once. And the good thing about it is you can have it done 3 or 4 times in your life without it apparently causing any side effects, so no harm from repeating it. So it's a very good option for people that are not tolerating their drops. There are other kinds of laser, and the most common other ones would be cyclodiode or endocyclodiode. Endo just means you do it from inside the eye. If you don't see that endo, it's done from the outside, and that kind of laser ablates the ciliary body to reduce the amount of aqueous that's produced. So it's quite a destructive procedure, and it's only used for people that nothing else has worked. Now on to the surgery. Well, the two commonest surgeries performed in glaucoma are trabeculectomy and cataract surgery. So the traditional surgery for glaucoma that's been around for decades is trabeculectomy. The problem with trabeculectomy is it's a bleb-forming procedure, and if you've ever had surgery, you will hear your specialist talking about your bleb. So what trabeculectomy does is it makes a connection between the front of the eye, the anterior chamber, and the outside of the eye with a little flap. So if you look in the top picture, that is where the flap is. When that little black square fades away, you'll be able to see underneath there's a little flap, and underneath there is the aqueous draining out very slowly. That top patient has a beautiful thin flat bleb that's not going to cause too much trouble, but the patient at the bottom has not been so lucky. That is the problem with blebs. They're totally dependent on individual wound healing, and you can get these big raised blebs that are quite uncomfortable under the eyelid and can leak. So blebs are something that we have spent decades trying to not make, to find procedures that don't make a bleb. So the pros of trabeculectomy is that it's usually possible to get a pressure close to 10, which is what we want in most people with bad glaucoma. You can get a very low pressure. Very few of the other procedures get the pressure that low without drops. You can use releasable stitches at the time of the operation and tie them quite tight so that the eyes are not too soft after the operation, and you can remove them over the next week or two if the pressure needs to go lower. So it's an adjustable operation. But the big cons, well, number one, it's that bleb. Number two, it's dependent on the individual. Each eye feels totally different when you do an operation on a trabeculectomy operation, because some eyes have thick white of the eye and some have thin, some have thick conjunctiva, some people have very friable conjunctiva, and everyone's wound healing is different. So young people tend to heal over their trabeculectomy site very quickly and it fails for them, but older people can do really well. Their trabeculectomies can last a lifetime if they're lucky. It's quite variable how long trabeculectomies will continue to function, but many do eventually fail, unfortunately. So onto cataract surgery, which is actually probably the most common operation performed for glaucoma. You wouldn't think that, but it is a tool that we use to treat glaucoma. Cataract surgery involves replacing the natural lens, which you can see that pale creamy structure in the middle of the eye, with a clear artificial lens. Great thing about these artificial lenses, you can put in any strength you want, from about -8 to about +32. So anyone that has got a refractive error such as long-sightedness or short-sightedness, that can be fixed. So there's more than one benefit of cataract surgery, and you exchange a slightly cloudy lens for a beautiful clear one that's only a third of the thickness of a normal human lens. So this usually lowers the pressure for a few years. It widens the drainage angle, stimulates the immune system to clear out the trabecular meshwork, and another thing that you can do is you can use MIGS at the time of at the time of cataract surgery. I'll talk to you about MIGS in a slide coming up. So minimally invasive glaucoma surgery can be done at the same time as cataract surgery. It's usually very safe and can reduce the need for a spectacle wear, but some people can run into trouble after their cataract surgery with inflammation, especially if they've been on glaucoma drops like prostaglandins in the past. And the steroid drops that you have to use after the operation can make your pressure go up after cataract surgery for up to 6 weeks. The dry eye often gets much worse after cataract surgery. Dry eye always gets worse after cataract surgery anyway, and if you've got glaucoma, it's even worse. Some people really struggle to get on top of their dry eye afterwards, and any operation can have complications. An operation on the inside of the eye can lead to blindness. That's vanishingly rare, but it's always in the back of our mind when we decide to do an operation. So that's why we usually try drops or laser first. Okay, now we're back to the bleb. These are various implants that are used for managing wound healing. Unfortunately, all of them make blebs. So you'll see on there the Zen stent, which some people call MIGS, a minimally invasive glaucoma surgery device, but actually it makes a bleb. So most of us feel that you can't call it MIGS because it's invasive and it makes a bleb. We don't like blebs, although when they work, they're very good. So I'm going to start with the Zen stent because that would be probably the most common proper glaucoma operation that we're doing in Western Australia at the moment. It was invented in Western Australia, and I've looked after some of the patients that had their Zen stent in more than 12 years ago by Prof. Morgan when he invented the stent. That old Zen stent, it was a different design, that it is still working well for those patients, which is interesting because what happened is Zen got bought and commercialized, and the new Zen is slightly different. It's smaller and thinner. When you put them in, sometimes there's a little bit of leakage of fluid around the edge and the pressure can go quite low afterwards, and the gelatine is a little bit different from the original gelatine. I know personally that patients I've put Zens in, they probably haven't had quite as a high success rate as the original Zens that were made in Perth. Maybe it's my technique, but I also get that impression in general at the Royal Perth Glaucoma Clinic, that the failure rate of Zens is quite similar to trabeculectomy. They require a lot of management of the wound healing to make them work, but when they work wonderfully, and often the bleb's not as big and problematic as it would be with a trabeculectomy. So in the second picture down, you can see a tiny little dot on the bottom, just to the right of the edge of the picture. That's the Zen on the inside of the eye. And then the picture below that is an ultrasound, and you can see that they're quite soft, so they take the shape of the wound. They can, it's not like putting a piece of metal or silicone in the eye. They're a little bit more compatible than that. People have been trying to stop the eye healing up for a very long time. Other devices which are possibly along the same line are the Express shunt, which is a stainless steel implant. That was really popular when I was training, but it's lost its popularity because there is a bit of a risk that they can erode through the eye. They are still used. And then a new one is called the Preservision, and it is made of a new material called SIBS, which is supposedly more biocompatible. It's early days yet. People other than Western Australians are being the guinea pig on this one, so we're not using it here yet. We'll just wait and see if it turns out to be better than what we've got here. So up at the top are the real big guns, the Multino tube Barvelt and Ahmed valve are the devices that we use for glaucoma that is very, very difficult to treat. So people that have secondary glaucoma from diabetes or from inflammation in their eye, or people that have had 2 or 3 failed glaucoma operations because their wounds just heal too well. All of these have quite a thick tube that goes into the eye. So the one on the left I've used a Multino tube. That's the one I grew up with and learned to implant when I was a trainee, because I'm from Cape Town and it was developed in Cape Town. So I have a little bit of an allegiance to the Multino tube. Professor Multino moved to Dunedin and carried on his research there. He's retired now, but he has the longest term follow-up of any of these implants. Really, really impressive follow-up, and the understanding of how they work and how you manage the wounds is very, very good. So that is my favorite, but I do also use Barvelt tubes. That's an American competitor. Just they're sometimes easier to get hold of and they're very similar to put in. They claim that they're less likely to cause muscle imbalance. These things are big and they go in between the eye muscles, but in my personal experience, I think that Multino has caused less problem with the muscles. Because the tube is so big, if you just put them in and leave the tube open, the eye will go very soft and the pressure will go very low straight after the surgery. So you have to tie the tube off with a dissolvable stitch, which dissolves 6 weeks after surgery. It's all a bit of a roller coaster because the pressure's high straight after the operation. Then all of a sudden, 6 weeks later, even if that's on Christmas Day, which has happened to one of my patients, the pressure suddenly drops down to very, very low. And then it slowly climbs up again, often to too high. And then the wound remodels itself over 6 months to a year. And then people can end up with a really long-term good pressure control. These are devices that are most likely to be lifelong devices more than any of the other glaucoma surgery. So it's really, really major surgery, really, really hard work, but they keep going for a long time. So the pros of these devices that aim to stop wound healing, or they work well for complex glaucoma and have the best long-term survival, but the con is that they all make a bleb, and the surgery is more major than with MIGs, and they require a lot of maintenance, a lot of back and forth visits. Even Zens, which are probably the most minor of all of those, we have to use medication under the conjunctiva and constantly break down scar tissue in order to keep them working. Now on to non-bleb surgery, or mixed minimally invasive glaucoma surgery, or trabecular surgery. The commonest of these is the eye stent inject. So I've put in a couple of those this morning, usually done with cataract surgery, but the eye stent has been successful and safe enough that the TGA and PBS last month said we can now use them in patients that we're not doing cataract surgery on. We can do them as a standalone procedure. I'm going to wait and see what the results of that are, because I know that some of the pressure lowering my patients are getting is because their cataracts come out, so I'm not sure how much pressure lowering they'll get just from having a plain eye stent in there. Anyway, the place that they're implanted is in the trabecular meshwork, which you can see on the right of the eye, those two round little metal dots. They're made of titanium and they're not magnetic, so you can still have an MRI scan, which you couldn't have with that other little one we saw, the Express. You can't have a very, very high power MRI scan, but you can have an MRI scan. And so they perforate the trabecular meshwork, and on the left you can see a little black hole, which is Schlemm's canal that goes all the way around the edge of the cornea. And so the eye stent's connecting the inside of the eye with that little tube. So they're pretty safe, they don't make a bleb. They've got less pressure lowering ability than bleb procedures though, and the long-term success is not known because they've only been around for a few years. But there's some indication that people might actually get pressure that gets lower over time as their Schlemm's canal starts to open up and function, and they get new little collector channels opening. So we'll have to see over the next few years. I've put in two little pictures that I've drawn because they kind of have gone out of fashion. The CyPass was a really clever device which connected up the anterior chamber to the suprachoroidal space, which is the space between the ciliary body and the white of the eye. And so that was a novel procedure. There was nothing else that did the same thing, and it worked really well. But the problem with the CyPass is it was quite a hard material, and when people rubbed their eye, it rubbed on the inside of the cornea, or possibly not even from eye rubbing. It did rub on the inside of the cornea and make the cornea go hazy, so it was withdrawn. And I think they're probably working on a new material because it's still an amazing idea. The Hydrus is a metal stent that gets fed into the trabecular meshwork and opens it up, so it's quite similar to the eye stent. I do know one surgeon that was doing them in Perth, and I was talking to him about them, and he felt they're quite tricky and the complication rate is higher than with eye stent. So I think most people have moved to using eye stent a lot more than Hydrus, but it is something available in Australia. And then there are a whole lot of other procedures with names, all of which are a variation on a theme. So when I was training, there was a procedure called viscocanalostomy, which was pretty popular. You injected gel into Schlemm's canal, and it supposedly reinvigorated it and got it working. Certainly did drop the pressure for a while, but it wasn't a very long-lasting procedure. It is still quite popular in Europe. There are all sorts of other trabecular procedures such as GAT, ABIC, trabeculotomy and goniotomy. Trabeculotomy and goniotomy are mostly done in children. That involves actually incising the trabecular meshwork to open up Schlemm's canal. Some of the others are similar. Some of them involve feeding fibre optic probes into Schlemm's canal. It's all very technical and really exciting because it's just amazing that you can do that, put a fibre optic probe into Schlemm's canal, but the results are quite similar to the original procedures. They don't seem to lower the pressure as much. The survival possibly isn't as long, and they're quite commonly associated with a lot of bleeding in the eye at the time of the operation, so the surgery is probably not as safe as an eye stent. So I don't think there's anyone doing those in Perth. It all depends where you've trained, but Perth surgeons are quite conservative and they really like to know that things are safe before they do them. So that's all the devices. But there are actually other things that you can do in life to, one, actually you can prevent glaucoma to a little extent, and also you can improve your prognosis from your glaucoma. So the first thing, this is hot off the press this year, that a low-carb, veg-based diet reduces the risk of glaucoma by up to 30%. So this has come from a huge set of studies, a meta-analysis of 3 big studies in the US, some of which have run since 1976, so that's a very long time. And what is meant by a low-carb, veg-based diet? It's basically similar to a Mediterranean diet, lots of pulses and lentils and vegetables, less meat and dairy, and less simple carbohydrates like bread and potatoes and rice. So there you go. Hopefully at least my generation have the option of doing that while we're young enough to make it matter, or maybe we can get our children doing it. And we don't know yet if you have glaucoma, does it work, but it's a very healthy diet anyway, so it's a good recommendation to have a low-carb, vegetable-based diet. There are other lifestyle things that you can do. Moderate exercise at least 3 times a week can reduce the intraocular pressure by 20%. Not exercising for 2 weeks reverses this effect. Maintaining a good muscle bulk helps to increase BDNF, which is a nerve growth factor, which protects against both glaucoma and dementia. So this is really important, and I've seen it quite clearly in my patients who get a little bit frail because they've been admitted for some other health issue. All of a sudden their visual fields start to go downhill. Everything goes downhill, but when you lose your muscle bulk, your optic nerve definitely goes downhill. So they have proved that maintaining muscle bulk helps. They've proved it in people with glaucoma and measured this substance, BDNF, and they've proved it in a kind of rat that gets glaucoma. These rats had to swim for 2 hours a day. So if you're game to swim for 2 hours a day, it might help protect your optic nerve and stop you getting dementia, but I think any little bit is going to help. Trying to not get frail, maintaining your activity, trying to keep your muscles in as good shape as possible, because you can't take this substance by mouth, you can only make it in your muscles. Maintaining a normal weight reduces the chance of getting sleep apnea, sleep apnea can affect glaucoma. People quite often ask me about herbal remedies. So bilberry is a popular one. Bilberries are purple and they've got bioflavonoids, which are anti-inflammatory but haven't been shown to help in glaucoma. They probably have many other benefits though. Ginkgo biloba is used in Chinese medicine as a neuroprotective agent. In other words, potentially it could protect the optic nerve, but unfortunately it's got a lot of interactions, and if you take it, it messes with your other medications. Their levels can go too high or low because it affects your enzymes. So far they haven't proven that it works in glaucoma. Cannabis reduces intraocular pressure transiently for 3 to 4 hours. The problem is that fluctuating pressure is really bad for the optic nerve. It is not good to have your optic nerve trampolining through the day. So if people struggle to get their drops in once or twice a day, 3 to 4 hourly is just not going to work. But maybe cannabinoids will be developed into longer acting preparations down the line. Unfortunately not at the moment. And then there are all the side effects to consider, like dependence risk, psychosis risk, and the risk of cancer if you smoke it. Vitamin B is undergoing trials at the moment. It does seem to have some protective effects on glaucoma, but unfortunately there are also side effects like swelling up of the macula, nausea and dizziness. Lifestyle factors which may make glaucoma worse, including anything that causes valsalva. Valsalva is when you block your airways and breathe out, so there's suddenly high pressure which is transmitted to your eye. Probably the commonest cause of that is untreated sleep apnea, but also playing a high pressure instrument like an oboe or a French horn can do the same. Standing on your head for long periods of time doing yoga can put your pressure up into the 30s quite easily. So if you like yoga, perhaps stay the right way up or don't stand on your head. Wearing very tight swimming goggles can put your pressure up if your goggles are just touching the soft tissues around your eye, so it's better to wear bigger ones that touch the bone around your eye. And then if your blood pressure is treated by an over-enthusiastic GP or cardiologist to the level that you're actually getting dizzy, that's not good for your optic nerve. So it has been found by the Canadians that it's a good thing to have a difference between your eye pressure and your bottom reading of the blood pressure of about 54 millimeters of mercury in order for your optic nerve to be perfused. So if your eye pressure is 10, then the bottom reading of your blood pressure should preferably be about 64 or 65. And that same Canadian group has found that people who are running very low blood pressures, in addition to not perfusing their optic nerve, they're not perfusing their brain, and their cognitive function goes down. So that's pretty important. Suddenly drinking large amounts of fluid can put your pressure up. For example, if your homeopath advises you to drink 1 or 2 litres a day and you don't really want to do it, so you just do it all at once, that's not a good thing, because the eye makes all this fluid and then the trabecular meshwork just can't pump it out fast enough. So drink when you're thirsty, and if you need to have a higher fluid intake, try and spread it out. Caffeine can also raise your intraocular pressure for up to 3 hours, so that's a coffee. And then if you have something called pigment dispersion, which causes open angle glaucoma, you can get pressure spikes from your iris rubbing on your lens with activities like jogging, playing tennis, jumping on a trampoline. Probably most people with glaucoma aren't jumping on the trampoline too much. You can make your drops work better for you and reduce the side effects by taking a few simple measures. Firstly, be really regular. Find a way to remember your drops. Late is better than never. Most of them wear off after less than a day, but if you remember them a little bit late, it's best to just put them in. If you really let them wear off, then your pressure will fluctuate more and your optic damage will be, your optic nerve damage will be worse. I suggest that patients put their drops in the morning if they are somebody that gets up with an alarm clock, because what you can do is keep them next to your bed. As soon as that alarm clock goes off, you put them in, and then straight away you close your eyelid. If you block your tear ducts by putting your fingers just behind the little bony ridge under your eye, that stops them going into your nose. And closing your eye stops the pump of the eyelids pumping the drops into the nose. So that's where the side effects come from, and if they absorbed into the bloodstream from the nose. Most drop absorption takes place over about 4 minutes into the eye, so if you can keep those drops on your eye for 4 minutes, that's a good thing. And so if you wait 4 minutes between each drop, that's also a good thing. If you're on a prostaglandin, which is going to give you dark rings under your eyes and maybe even make your hair grow around your eyes, mop away any excess. That's the only advice I can give. You can still get those side effects though. So we're coming to the end now. Dry eye is probably the big reason that people think of having something other than drops to treat their glaucoma. Because if you have dry eye, especially if you've got rosacea or autoimmune disease, or you're taking antidepressants, or you work in a dry environment on a screen, your dry eye will get much worse from glaucoma drops, just because of the drops themselves and also from the preservatives that they contain. So you can try to use preservative-free drops. Your ophthalmologist probably is doing that already, but even so, the drops can make your dry eye worse. So some things that you can do: look after your eye surface. The eye is part of the brain. You wouldn't just let your brain hang out and dry, and you wouldn't pour chemicals all over your brain. So don't do it with your eye. Try to be kind to your eye as much as possible. Remember that when your eye is dry, the nerves on the surface lose their sensitivity, so you don't always know that your eye is dry until it gets blurry. It's not always painful. So if you do have dry eye, if you've been told you have dry eye, it's a good idea to try and use a lubricant drop at least 4 times a day, preferably without a preservative. So I put a long list of drops that contain no preservatives on the slide, and you can choose the one you like. Many of them are on the PBS if you've got severe dry eye, so you can get them on a prescription. If you're someone with rosacea or blepharitis, warm compressors can help. 40 degrees is the magic temperature. That's as hot as your hand can bear. 4 minutes a day is that's how long you have to do it, because that melts the oils in the oil glands and keeps the surface of the eye oily so that the tears don't evaporate. If you've got glaucoma, you don't want to compress too hard on your eye, so just use it as heat really, with some light pressure. A good omega-3 intake. Omega-3 oils are found in fish, chia and linseed, can also help those oil glands. I'm not a big one for pills. I think it's best to do it in your diet. So more omega-3 and less omega-6. Omega-6 is what you get in dairy and meat and canola and sunflower oil. And that is a very an anti-inflammatory factor in your lifestyle if you can have more 3 omega. So look after your eye surface. And that's all, folks. Thank you very much for listening. I hope you got something out of that talk.
Well, I'd like to thank Dr. Richards for giving us that amazing talk. I think you'll find that the diagrams themselves were very, very thorough and very useful for us, especially as we do often have difficulty with vision. So thank you so much for that. My name is Gayla, and I'm a volunteer coordinator for Glaucoma Australia, and they also support these meetings, as does the Perth Eye Hospital that have provided the venue here today and also set up for this video presentation. So extremely grateful for that. So I noticed that in the talk you gave today, you answered pretty much all of the questions that our members in WA had sent through.
Well, thanks for sending them through to me. That was really organised, and it made it much easier to write the talk, knowing what people wanted to know.
Yeah, that's terrific. But I just listening to your talk, there were a couple of other things that I'd like to ask about.
Go ahead.
And you did mention dementia, and of course my eyes pricked up immediately because you had said that dementia was a risk factor for glaucoma.
Yeah.
So I just wanted to ask you how it might be a risk factor.
Well, possibly the first thing to say is that glaucoma is not a risk factor for dementia. So if you have glaucoma, you don't need to worry. But the eye, as I was telling you, is part of the brain, the most important part of the brain. But dementia is a neurodegenerative group of conditions affecting the brain, and since the eye is part of the brain, the eye definitely is affected. Thinking back to my old dad who got glaucoma when he was 75, so I now have a 25% chance of getting glaucoma myself. One of the first things that happened was he crashed his car. He hadn't taken his optometrist's advice and gone to see an eye specialist, but the optometrist luckily was persistent and got in touch with an eye specialist, and the eye specialist was a friend of mine and got in touch with me and said, do you know your dad has not had an appointment? So luckily my dad eventually did get into the system, but he already probably had some visual field loss, and quite likely he already had some cognitive changes then. So the glaucoma and the dementia maybe were all part of the same process. And there are probably many genes that account for that.
Yes, very, very complex, isn't it?
Yeah.
It's easy to think, you know, we have one type of glaucoma, one drop fits all, but...
Yeah. You may know that you can image Alzheimer's plaques in the retina. They're not only in the brain, they are in the retina. And if you give people curcumin, in other words, turmeric, it's a fluorescent coloured substance. You can use a special retinal camera to image those plaques in the retina. So it may be a way of picking up Alzheimer's disease earlier. That's an experimental study that's on the go. Western Australia is doing some of that work at the moment, so it'll be really interesting to see what comes out of that.
Any idea when it might be ready?
No, but you might like to get Yogi from the CSIRO to talk to you, because he's been involved in that.
Excellent, thank you. What I know what else we had here. Yes, a big question that a lot of people grapple with, I think, because that question often comes up. And they ask that, is it better to have glaucoma surgery earlier because of the possible inflammation and corrosive effects that you get from the eye drops? How do you feel about that question?
Well, there have been proper prospective studies looking into that, and people for whom glaucoma surgery works can do better than people on drops, partly because you don't have the side effects of the drops, and also because glaucoma surgery drops the pressure lower and keeps it more constant. But the trade-off is that glaucoma surgery is a bit risky. Any operation on the eye has risks, including loss of vision, so it's always a really hard decision for us to operate on the eye, especially as glaucoma surgery doesn't actually make the vision better. So if people lose vision from glaucoma surgery, they can feel pretty terrible about having made the decision to go ahead. Personally, when I get glaucoma, you can ask this question to ophthalmologists in Perth, I think that the first thing I would do is have selective laser trabeculoplasty as things stand now, and I would hope that I'm one of the 60 to 80% of people it works for, but that's my opinion, and there is a very excellent glaucoma surgeon in Perth who has glaucoma and takes 4 different drops. So it's a really hard decision. People that do glaucoma surgery know what the complications and risks are.
Right. Yes, fair enough.
Hard decision.
Yeah.
But if your glaucoma is going downhill and your pressure is not well enough controlled on your drops, or your drops are giving you bad side effects, well, surgery is probably the answer there.
Yeah, excellent. And one last question from our glaucoma group was that have there been any studies comparing those who have glaucoma surgery to those who continue to use drops only? Are there usually better long-term outcomes from glaucoma surgery despite the risks of surgery?
There have been studies. It's difficult to do a randomized trial because the two are so difficult to compare. The side effects of surgery and drops are so disparate. You can't just put people into a group and say you're going to get the surgery and you're going to get the drops. So people need to be involved in the decision making. So most of the information about that is from retrospective studies where they just collect up people who've had glaucoma surgery and people who are on drops. Certainly the people who've had glaucoma surgery and are not on drops have fewer eye surface side effects. But in total, the people who've had surgery have lower eye pressure in general and more constant pressure. So if their surgery has worked and the operation didn't cause any problems, then they probably do better in the long term from a surface point of view and from a glaucoma point of view.
Excellent. Well, thank you, Dr. Richards. Thank you for this mammoth event. You know, you've come straight from surgery to talk to us, give up your time during the week. So Glaucoma Australia and all our members in Perth, we really appreciate your time. Thank you so much.
You're very welcome, and it's really great to be able to connect with everybody, even though we're all very socially distanced.
Yes, yeah, absolutely.
Thank you as well, Perth Eye Hospital, for making it happen. And I hope that everyone gets something out of it.
Yeah.
Thanks for organising it.